I will start by Ms. Mia Atoui and talking about mental health. And, you know, we have lots of challenges. Mental health sometimes is not needed only in conflict. It's needed even in regular situations. And, you know, you have an essential role in mental health support, not only for the affected community or the affected population, yet for the very important part, which is the healthcare professionals working in disasters, especially during conflicts. You know, during conflicts, they will be working in situations that are not really normal. They will be faced sometimes with extensive situations, extreme burnout situations, long hours, trauma that were never seen, especially in the latest war. And we had lots of trauma faced by lots of healthcare professionals. I want to ask you, and based on your experience, how can the psychological distress manifestations like the burnout and compassion fatigue, or even the moral injury for the healthcare professionals be effectively mitigated and managed within the high pressure conflict times, in addition to the how can be or what can be the challenges for giving the mental health support to the affected population during conflicts?
We'll answer this not so, it seems like a straightforward question, but it's not as simple as that. So I will take a few minutes actually to present from there, as I have a few slides I want to share. But before I share my slides, I actually want to start off by answering this question with sharing two personal stories and short reflections. Actually, building on everything that has already been shared so far, 2 weeks ago, a colleague of mine, a manager with me within my team, began our weekly leadership meetings by saying with one of those opening statements that frightens me usually. And she says, Mia, I would like to share something with you that I have been reflecting on for the past week. Actually, my heart sank a little bit when I heard this statement, because usually it ends up with a resignation. And, you know, we've been in a turmoil for the past few months, so I was not really ready to lose one of my main managers in the team. But she continued, and she told me, Mia, I want you to know that I feel it's only responsible from me in a leadership position to share with you that if we were to go through another crisis or war, I don't think I will be ready or that I am ready to lead our team and our operations through another crisis. Well, I took a breath of relief. It was not a resignation. But her statement left me momentarily confused. Now, if I were to put my manager hat on, my first inclination would be to, you know, jump into some open-ended questions, you know, ask her what would help you to become more ready. What should we do? Should we problem solve? Should we work better on our emergency preparedness plan so that, you know, what will help you to be ready to lead the team through another war or crisis? But actually, I paused and I tried to respond with what seemed to me to be a more logical response in this situation, which is, I don't think anyone is ready for another war or is expected to be ready or to ready themselves to endure war again. And even though Dr. Shadi's opening remarks were all about that, I beg to disagree on this. We have yet to process everything that we have been through in the past few months. So preparing for another future crisis, I don't think is something we're ready to do. So, and I don't think readiness for war should be the defining measure of a leader or a manager's capabilities or competence. And I think we've reached, in spite of our need to be here, and definitely the importance of this conference and conflict medicine, I think it's a dangerous place to reach when our minds and our nervous systems need to feel the duty to ready themselves as a matter of, daily living and as a measure of our competence and skills to be ready for war. In the last final days of the ceasefire as well, I found myself experiencing some increasingly intense emotions every time there was an airstrike on Beirut's southern city. And I say increasingly intense because obviously we were experiencing different emotions, but I felt that the last few days were especially difficult for me. And I remember that I felt that each explosion that was hitting Beirut, I remember saying this, felt like a knife that was piercing through my chest. And I remember that I stopped a little bit and I questioned, and I started to worry a little bit, I have to say, about the way I was describing this pain. And I asked myself whether I was beginning to personify the pain of my city, and whether the intensity of my emotions was actually signaling something that was more clinically concerning. And as psychologists, we are trained to be, hyper aware of when distress really begins to cross the line, even if slightly, into something more serious and indicative of maybe a deteriorating mental health condition. So why am I sharing this? I'm sharing this because war obviously does not just impact the people who are in combat or the people who lose their homes or their loved ones, but it also impacts us as healthcare professionals. It really seeps deep into our psyche, and it distorts the boundaries between what we think is normal or what we are taught to be normal and what is abnormal. It also blurs the boundaries between what is personal and what is collective. It really forces us to rethink about resilience, to question whether enduring is truly a sign of strength, and to wonder in the process of this all how much we lose, how much of ourselves we are losing. So that, to begin with, and Abir, to answer your question, is one of the primary challenges that we face as psychologists and as human beings in general in the face of the atrocities that we have witnessed in the past few months. And even though I have accepted to speak at this panel, I cannot claim that I have the answers on how we should begin to effectively manage and mitigate these challenges. But shortly after the war, our team of psychiatrists actually reflected on their experiences in these very short 2 months when the war escalated between September and November. And we have written out this paper that is now being reviewed for publishing. And I have to say that the primary aim when we started writing this paper is actually, I think we needed a space where we could put our thoughts, our reflections, our experiences. And the purpose was obviously not an academic analysis, but a space for us to reflect. And our paper really highlighted that we have key learnings that we need to reflect on and integrate. The first one is, I think, being stuck in this double effect between beneficence and non-maleficence, and how we face the challenges of providing ethical standards of care that are obviously become blurred in conflict. So this is a picture of us delivering mental health services, our team of psychiatrists in a public school, in a shelter. You can imagine that it was an open space. Everybody could see everybody. Every single person who came for a psychiatric consultation was seen by the whole school and persons in the shelter. These individuals were in high distress. They came often crying, sometimes suicidal. You can imagine what they were going through. And one of the main challenges we had to navigate every time we left a school or a shelter, did we engage in more harm or benefit to these individuals? Because the first thing we did is we compromised some of the main principles of our profession, which is ensuring confidentiality and anonymity to these individuals. But at the end of the day, prioritizing mental health care and not withholding this care for us seemed to be the priority. But it was something that we held on our conscience. The second thing, and I think Dr. Abu Sitta also talked about it, yes, we are ill-equipped in integrating mental health care and basic psychosocial care into our services. So this is the reflection of one of our psychiatry residents who was with us also on the ground. And he really felt overwhelmed and perplexed by the idea of how he can deliver psychiatric care and make an assessment and prescribe treatment when these individuals really lacked everything in terms of basic needs. So he really said things like, you cannot talk about coping strategies. I cannot implement what I learned in medical school with these individuals. And this is because his training was not really informative of how to work on the field in these conflict situations. So we definitely need to do more in terms of integrating holistic psychosocial support to our medical residents, to our non-specialized mental health workers, to our psychologists. Another challenge that we also faced is to diagnose or not to diagnose. And now this might be a simple question, of course, for psychiatrists and psychologists who are well trained. Okay, we know the difference between how to differentiate between acute stress disorder or post-traumatic stress disorder. We've learned that in our medical training. But what we have not learned is how to put into practice the cultural nuances and the cultural differences to understand how distress might be expressed in different populations that we have not seen maybe in the clinic or in the same situations that we see these individuals during conflict. And here there's really a fine line between obviously pathologizing adaptive coping behaviors and also normalizing unhealthy coping. But if we are not trained on cultural sensitivities, this fine line can be easily crossed and we can go back into making mistakes and doing more harm when we are working in conflict situations. So really our training and the training of both, I believe, psychiatry, mental health professionals, residents, psychologists, and even social workers needs to be more attuned to cultural narratives. This is something missing in our educational training so that we can understand better the experiences of the persons we work with. Abir, to reflect back on your question, what do we do and how do we take care of ourselves as mental health professionals? The term self-care, I think, has become very commercialized, very overused. So I think what I would like to replace it with more is self-discipline. And this is something that even though maybe we learn indirectly in our training, but there's not enough training that is given neither to residents, and I speak of psychiatry residents more today in terms of the mental health professional, because we do get a little bit of that as psychologists and psychologists in training to learn how to self-reflect, to be aware of our needs. But also we can, if we don't engage in enough training on that, we can also skip the boundaries. And when we do that and give more of ourselves and not be aware of our boundaries and our need to also engage in self-care during these situations, we can definitely do more harm to the populations that we are serving. I will end a little bit with this, with the last few slides, in the sense that our reflection during the past few months also highlighted the need to institutionalize also peer support and support for mental health professionals. It cannot be given just naturally, or we cannot wait for mental health professionals to reach the burnout level or to reach the point where they are making mistakes in their their profession as a result of mental health problems or burnout or compassion fatigue. We need to put in place ways in which these individuals also are quote unquote forced to go into this. Our experience is that it's not easy, but it has to be done, where we create places for these individuals to debrief and to be able to share their experiences. And I think this was the thing that I believe supported our community, our mental health professionals during this period. We both made sure that there was an organized structure in which they could engage in debriefing after traumatic or difficult incidents on the field, but also the most important thing I have to say is the importance of peer support and being able to get support from their community. So healing from moral injury or compassionate fatigue is not just also about self-care. It's being able to find a community in which individuals can feel that there are others where they share similar values. So actually, these are some messages from some of our WhatsApp groups in which our volunteers, both on the National Lifeline as well as our clinicians, continuously during this process were providing this very close emotional support to one another so that they can build back and feel that they still belong to a community where there are shared values and where they can really find solidarity and strength to collectively navigate this situation. And I think this is one of the main things that we will need as mental health professionals to continue to navigate these situations. Thank you.
Thank you so much.